Okay, picture this. You have a patient, let's call her Aparna. She's 35 years old, lives in Hyderabad, and she is, otherwise totally healthy. But she walks into a clinic with a mystery that seems, on the surface, incredibly mundane. She has a stuffy nose.
And usually that's where the story ends, right? You'd prescribe a nasal spray, maybe some antihistamines, tell them to buy a humidifier, and send them home.
Right.
But in Aparna's case, the details tell a completely different, much more complex story.
Exactly, because this isn't just a sniffle or some seasonal allergy.
Yeah.
She has a blockage, but it's strictly on the right side. And here is the detail that immediately hooked me on this case. The blockage gets significantly worse when she breathes out.
Which is the exact opposite of what most people expect. Usually, if your nose is blocked, you struggle to pull air in.
Right. And to add to the weirdness, it gets worse when she lies down. So today, our mission is to play detective with this single clinical case. We aren't just talking about a blocked nose. We're going to use this case to unpack the physics of airflow, explore how brain herniations can disguise themselves as simple polyps, and look at the high-stakes detective work required to operate inside the human head.
It's really a lesson in observation. It's about how a single, subtle symptom, like the timing of a blockage, can be the difference between a routine procedure and a catastrophic surgical error.
So let's start with the clues. We have Aparna, 35 years old, a homemaker. She tells the doctor this obstruction on the right side has been creeping up on her for 6 months. It's insidious.
That word insidious is your first major clue. Words matter in medicine. If she came in saying, I woke up yesterday and couldn't breathe, you'd immediately think of an acute infection or maybe trauma.
Like you walked into a door or something.
Exactly. But a slow 6-month crawl, that just screams growth.
It implies something is physically taking up space and just getting bigger over time.
Exactly. It suggests a neoplasm, a new growth. Whether that's a tumor or a polyp, we don't know yet, but the timeline rules out your standard cold virus.
She also mentions discharge from that side for about 4 months, and lately she's been snoring like a freight train. But I want to go back to that weird breathing symptom. She says the blockage increases during expiration. When she exhales, the nose plugs up. Why?
This is pure physics. It's a phenomenon we call the ball valve mechanism. To understand it, you have to visualize the airflow inside your nasal cavity. It's not just a static tube. When you breathe in inspiration, the air current flows aggressively from front to back.
Okay, so the wind is blowing into the tunnel.
Right. Now imagine you have a polyp attached by a stalk. When the wind blows in, that current, combined with the negative pressure your lungs create, actually pulls that mobile mass backward.
So breathing in pulls it out of the way.
Exactly. It pulls the cork out of the bottle, so to speak, opening the airway slightly. You get a moment of relief, but when she breathes out, the airflow reverses.
And the pressure pushes it forward.
Yes. The air pushes the mass forward, jamming it into the narrower part of the nose. It plugs the hole tight.
Like a check valve?
Precisely, and that tells the doctor something instantly before they even look up her nose. It tells them this mass is mobile. It's not a tumor fused to the bone. It's something on a long stalk, flopping back and forth with every single breath.
That is such a cool deduction. And then there's the second clue, gravity. It's worse when she lies down.
Two things are conspiring against her there. First, plain old gravity. If this mass is rooted in the back, lying down allows it to fall backward into the choana. That's the back door of the nose leading to the throat. It basically settles into the doorway.
And seals it off. And the second factor, I'm guessing it has to do with fluids.
It does. It's called venous pooling. When you're upright, gravity helps drain blood from your head. When you lie horizontal, the blood pressure in your head increases a little. The blood vessels in your nasal lining, especially the turbinates, swell up.
Oh yeah, we've all felt that when we have a cold.
Yeah.
You lie down, and suddenly your head feels 10 pounds heavier.
Exactly. Now imagine your nose is already 90% blocked by a giant polyp. That extra 10% of swelling from lying down isn't just an annoyance, it feels like a brick wall.
Now speaking of those blood vessels, there's a negative clue here that I thought was really important. She tried decongestants, and they did absolutely nothing.
That is a critical negative finding. Think about how those sprays work. They're vasoconstrictors. They chemically shrink blood vessels. If you have a cold, your tissues are swollen with blood, you spray, the vessels shrink, and you can breathe.
But for Aparna, it was like water.
Which tells us the blockage isn't made of blood vessels. It's not an inflammatory swelling like you get with an allergy. It suggests the mass is, well, it's essentially dead weight. It's vascular.
Okay, so we've got a mobile, solid mass. Let's talk about the snot factor. Her discharge was mucoid.
Right, and in the detective game of rhinology, the type of discharge is a major fingerprint. Mucoid means thick and mucus-like. It suggests a chronic obstruction or a low-grade infection.
As opposed to what? What would be the bad kind of discharge?
Well, if it were watery and clear, we'd think allergies or maybe, and this is rare but real, a CSF leak.
Brain fluid. Yikes.
Yeah, if it were bloody, we'd be on high alert for cancer. And if it were foul-smelling, really bad, we'd be looking for a foreign body.
Like a bead stuck up there from when she was a kid.
Exactly, or a nasty fungal infection. But hers was just thick mucus, no blood, no smell. So the history gives us a sketch. A mobile, solid, non-bleeding mass. Now, the doctor actually has to look.
And what do they see? Anterior rhinoscopy.
They look in the right nostril and see a solitary, pale, glistening mass. The source material compares it to a peeled grape.
Which is oddly specific and a little gross.
It's actually a very accurate visual. It looks smooth, translucent, almost pale gray or yellow. But seeing isn't enough. You have to touch it.
This part surprised me. They actually pick up a tool called a Jobson horn probe and poke it. Isn't that risky?
It's a calculated risk, but a necessary one. The probe test gives you tactile information a scan sometimes can't. First, they check for sensitivity.
Does it hurt?
Exactly. Normal nasal tissue is highly sensitive. If you poke it, you tear up. In Aparna's case, the mass was insensitive. She couldn't feel it. That confirms it has no nerve supply.
Which supports the polyp idea, right?
Right. Then they check consistency. It was soft again, like that grape. If it were rock hard, we'd shift our diagnosis to a rhinolith, a literal stone.
And the big one, bleeding.
Huge. Crucial. They touched it, moved it, and it did not bleed. That virtually rules out vascular tumors or cancers, which are friable. They crumble and bleed at the slightest touch.
So since we know it's mobile from the ball valve thing, they use the probe to verify that.
Yes. They pass the probe all around it, over, under, to the sides. This is to find where it's attached. And if you can pass the probe all around it in the front of the nose, it means the root isn't there. It's coming from somewhere else.
Which leads them to put a tiny mirror in the back of her mouth. Posterior rhinoscopy.
Yeah.
And that's where they see the other end.
Yes. Using a St. Clair Thompson mirror, they see this globular mass just hanging into the choana. So putting it all together. They land on the diagnosis. It's an antrochoanal polyp, an AC polyp.
Okay, let's break that name down. Antrochoanal. Sounds like a geography lesson.
It is a geography lesson. Antro refers to the maxillary antrum. That's the large sinus cavity inside your cheekbone. That is where this polyp is born.
Antrochoanal.
Refers to where it grows towards the choana, the back opening of the nose. So the name literally tells you the journey of the polyp.
The sources describe it as trilobed. It has 3 parts.
Think of it like a dumbbell with a long handle. You have the antral part, the root inside the sinus. You have the nasal part, which is the bridge squeezing through the opening. And you have the choanal part, the big bulb hanging in the airway.
Here's where it gets really interesting to me. Why does it grow backward? Why not just come out the front nostril?
That is a fantastic question. The answer lies in microscopic anatomy. Our sinuses are lined with cilia, tiny microscopic hairs. These hairs beat rhythmically like a wave. Their job is to move mucus out of the sinus.
And the exit is in the back.
In the maxillary sinus, the natural opening, the ostium, is up high and towards the back. The cilia beat toward that opening. So the polyp is effectively riding a conveyor belt.
So the little hairs push it out of the cheek. Then what grabs it?
The airflow we talked about earlier. The inspiratory current breathing in is powerful. It drags the polyp backward. Plus, the floor of the nasal cavity naturally slopes downward and backward.
So you've got the conveyor belt of hairs, the wind tunnel of your breath, and the slope of the floor. The path of least resistance is backward.
Precisely. It's a perfect storm of anatomy and physics forcing this thing into the throat.
Now, before booking the OR, they had to play the what else could it be game, the differential diagnosis. This felt like walking through a minefield.
It is. This is the high-stakes part of medicine. You have to rule out the dangerous imposters. Because if you mistake a polyp for something else and just yank it out,
Oh, man.
you could cause a catastrophe.
Let's run through the lineup. What's the first one that keeps doctors up at night?
Malignancy. Cancer. A cancerous mass wouldn't look like a pale, glistening grape. It'd look fleshy, maybe pink or gray with open sores. It'd be hard, fixed in place, and painful. And Aparna's profile just doesn't fit.
So cancer's unlikely. What about the fungal infections? There's one that sounded like produce.
You're thinking of rhinosporidiosis. It's common in parts of India, and it looks strikingly like a strawberry red with a bumpy surface studded with tiny white dots.
A strawberry in the nose. And our polyp is a peeled grape.
Correct. And the strawberry bleeds very, very easily. Aparna's mass didn't bleed. Then there's the inverted papilloma. That one looks more like a mulberry granular and velvety. Benign, but it's aggressive.
Okay, grapes, strawberries, mulberries, a fruit salad of pathology. But there's one imposter that sounds absolutely terrifying. The meningoencephalocele.
This is the one you cannot miss. A meningoencephalocele is a herniation of brain tissue, and the meninges, the brain's covering through a hole in the skull.
Wait, so actual brain tissue is hanging down into the nose?
Yes. Now imagine if a doctor thought, oh, just a polyp, and tried to snare it and pull it out.
Oh my God, he'd be pulling on the brain.
You would rupture the barrier to the brain.
Yeah.
You could cause a massive CSF leak, meningitis. It's a nightmare scenario.
How do you tell the difference before you pull?
You look very closely. A meningoencephalocele isn't pale yellow, it's often bluish or gray, but the key sign is pulsation. It pulsates with the brain's rhythm. And there's a specific test, the Furstenberg test.
What's that?
You can compress the jugular vein in the neck, or if it's a baby, you just wait for them to cry. If the patient strains, the pressure inside the skull goes up and the mass in the nose actually expands.
That is horrifying and fascinating. So if the mouse gets bigger when they strain, do not touch it.
Do not biopsy it. Do not pull it. You refer to neurosurgery immediately. Aparna's mass was pale, didn't pulsate, and didn't expand, so they felt safe.
There's one more weird one, the rhinolith, the nose stone.
Yes, a foreign body gets stuck, and over years, calcium deposits on it. It becomes a stone. But that would be rock hard. Hers was soft.
Okay, so they've ruled out the brain, hernia, cancer, fungus, the stone. It is definitely an antrochoanal polyp. How do you fix it? Pills don't work.
Right. Unlike other nasal polyps, which can be allergic, AC polyps are usually infective. Steroids don't touch them. The only way out is surgery.
And the surgery of choice is FESS.
FESS.
Functional endoscopic sinus surgery, the gold standard. The idea is to be minimally invasive. We want to restore the plumbing without destroying the house.
So walk us through it. They go in with a camera.
Right, an endoscope through the nostril. First, they often do a polypectomy. They remove the nasal part of the polyp just to get a clear view, but that's not the cure.
Because the root is still hiding in the cheek. Exactly. So they have to find the door to the cheek sinus. They perform an uncinectomy. This means removing a small sickle-shaped bone called the uncinate process. It's like a gatekeeper hiding the opening.
So they take out the gatekeeper bone. Then what?
Then they perform a middle meatal antrostomy. That's a fancy way of saying they widen the natural window into the sinus, making it large enough to see inside.
And once they are inside the cheek sinus,
We'll grasp the stalk of the polyp, the root, and remove it completely. This is the key. You have to get the root.
the source mentioned an older surgery, the Caldwell-Luke operation. That sounded way more barbaric.
It was. Before we had good cameras, they would actually make an incision inside the mouth, under the upper lip, and drill through the bone of the face to get in.
Drilling through the face.
It was. It caused cheek numbness, swelling. FESS is all done through the nostril. No external cuts. But FESS isn't without risk. We're operating in a very crowded neighborhood.
I was looking at the anatomy charts.
Mhm.
It's frighteningly crowded.
Extremely. You are millimeters away from the orbit, the eye socket.
Mhm.
One slip and you can cause double vision or worse, blindness.
And what about the roof?
Just above you is the cribriform plate, the paper-thin bone separating the nose from the brain. You go too high, you're poking the brain.
It really puts that simple probe test into perspective. You want to be 100% sure of your landmarks.
Absolutely. The diagnosis guides the surgeon's hand. Precision is everything.
So for Aparna, the outcome was good.
Yes, the surgery was successful. They removed the trilobed mass, cleared the sinus, and she could breathe again. No more snoring, no more ball valve.
I think my biggest takeaway from this deep dive is just how complex the geography of the head is. We treat the nose like a simple tube, but it's this complex machine with valves and conveyor belts and hidden rooms.
And it highlights the importance of the patient's history. Just listening to her say, "It's worse when I breathe out," unlocked the physics of the diagnosis. It's a reminder that the body is a mechanical system, and sometimes you have to think like an engineer to solve a medical mystery.
Truly, I'm never going to look at a stuffy nose the same way again. Next time I have a cold, I'm going to be lying there testing if it blocks when I breathe out, wondering if I have a ball valve mechanism kicking in.
Hopefully it's just congestion. But if it's strictly one-sided, maybe go see an ENT.
Good advice. That wraps up our deep dive into the antrochoanal polyp, from a mystery blockage in Hyderabad to a masterclass in nasal physics. Thanks for listening.
Stay curious.